Yes.
Ashmita, can you hear me? Yeah, good.
So good evening, everyone. I think we will display some slides just to introduce the organization to those who have joined us already. ITS was established in 2003, and it's a national body for healthcare professionals with a special interest in thyroid disorders. It was the founder president was Professor Jayakumar, and the current president is Professor Sarita Bajaj, and she is ably supported by a team of office bearers and 12 executive committee members who are all senior endocrinologists or endocrine surgeons in the field of thyroid disorders. So if you look at the aims of Indian Thyroid Society, I mean, predominantly we wish to promote public education awareness of thyroid disorders, and that's what we are doing. We also are organizing quite a lot of academic activities. We have been very active this year. We are encouraging research in thyroidology, which is one of our main focus. And our flagship journal is something which many of you are aware of, the Thyroid Research and Practice. We also intend to award fellowships to the experts in the field of thyroidology. This is something which is ongoing. Our current academic activities we are focusing on quite a varied or a variety of activities, starting from journal clubs to monologues, duologues, as we have this evening, panel discussions, case presentations, quiz, which has been a resounding success over the last few months, workshops, CPCs. So we're just looking at a variety of activities. We also celebrated May 25th, which, as you all know, is World Thyroid Day. And we intend to have quite a lot of activities in January, which, as you all know, is a thyroid month. Coming to research, which is what we are very keen to support, we have already invited research projects which will be supported by financial grants from the Indian Thyroid Society. So that is something which is happening at the moment. The journal, as I said earlier, is being published twice a year in print and online. There is a very quick turnaround time, so I would encourage all of you to actually consider our journal. We are already put in applications for indexing, so hopefully that will come through in the next few months. The fellowship, as I said earlier, is something which we are planning to give or confer to experts in the field of thyroidology who have contributed or who have made significant contributions to this field. In 2012, under the able guidance of Professor Jayakumar, the first clinical manual of thyroid disorders was published. And now we are in the process of moving on to the second edition. Professor Sarita Bajaj and Dr. Rajesh Rajput are the editors. That should happen this year. So it's already in the process. Also, there have been a variety of consensus guidelines that we have published over the years, starting from thyroid dysfunction pregnancy to subclinical hypothyroidism to dyslipidemia and depression, all in the field in the context of thyroid dysfunctions. So all these are available. Now we hope to relook at subclinical hypothyroidism and thyroid disorders in pregnancy in view of the most recent evidences around this, and also look at consensus guidelines on thyroid carcinoma. So hopefully all this should be out in the next year. We would also encourage you to visit our website, which is indianthyroidsociety.in, as you can see there. And we have been making active progress in making that website useful for everyone. Let me also invite you all to join, for those who are not members of the ITS. We have got two types of membership, the full life members for specialists in the field of thyroidology, and associate life membership for all registered medical practitioners. All MCA registered modern medical practitioners are eligible to be ITS members. So please follow this link, and this is available on the website, and you can please go in there and you can actually register online and become a full life member. Thank you. So I think it's 8 o'clock and just past 8. So time for us to start this evening's thyroid clinics. This over the last 2 months, as I said, has been a big hit, and we have had wonderful talks and contributions over the last 2 months. So for this evening, we have got a combination of duologue, monologue, and quiz. And to introduce the topics and to take the session further, let me welcome our chairperson for this evening, Professor Sujoy Ghosh. Sujay, as you all know, is a professor of endocrinology at IPG MER in Kolkata. He has held various positions in ESI, Indian Thyroid Society, RSSTI. So he's contributed significantly already to endocrinology, published vastly, and I think he has made headlines recently with his publications in some of the high impact journals in endocrinology, including JCF. So over to you, Sujoy, to take this session forward.
Thank you very much, Dr. Arun, and a big thank you to ITS for having given me this wonderful opportunity to interact with all of you. And we are going to kickstart the first session, which is going to be a duologue, and that is going to be presented by two wonderful speakers. Firstly, it's my pleasure to introduce Professor Bashir Lawe, who's the professor and head of Sher-e-Kashmir Institute of Medical Sciences, Srinagar, Kashmir. And the other speaker is none other than Riaz. I'm fortunate that Riaz was one of our DM trainees when I first joined the institute back after coming back to India. And he was one of our brightest students. He's currently Associate Professor of Endocrinology at Sher-e-Kashmir Institute of Medical Sciences, Srinagar. He's MD, DM, and he has special interest in disorders of the adrenals and the parathyroid gland, DSD and genetics of endocrine disorders. As a young endocrinologist, he's won several awards, including awards during ESICON 2011. And he has already established himself as a researcher and has published widely in national and international journals with more than 50 international publications. And the topic that they're going to talk about is very interesting because they're going to talk about unusual presentations of thyrotoxicosis. Now, thyrotoxicosis in clinical practice is not uncommon. It's pretty common, but they are going to tell us a bit about the relatively less common and the unusual presentations of thyrotoxicosis. The stage is all yours, Professor Lawe and Dr. Riaz.
Thank you, Sujoy. Thanks, ma'am, for invitation for this Indian Thyroid Society. So we will be discussing about unusual presentations of thyrotoxicosis. We know thyrotoxicosis has surprised us since we joined the medical school. So at MBBS level, once we appeared in MBBS, we were taught that thyrotoxicosis is very easy disease to diagnose because of florid symptoms. Once we went for post-graduation, then we start to learn about that thyrotoxicosis. We need to find out what are the causes. Like if there are different causes of thyrotoxicosis, and we need to make a plan for management. But at our post-DM level, once we were consultants and faculty, So we started seeing that thyrotoxicosis is not all that easy, and there are lots of atypical presentations, and these atypical presentations continue to surprise us, and this will continue till we will be in the practice. So today we will be presenting some atypical presentations of thyrotoxicosis, that is Graves' disease. Dr. Riaz will be presenting. Then next we will be reviewing the literature. Next we will be putting 3 to 4 cases which we have published. These are again atypical presentations. And at the end, I would like to take, if there are some questions from the audience, and then we can sort of go away with it. So over to Dr. Riaz, Ms. Please start.
A very good evening. At the outset, thanks to the Indian Thyroid Society for giving us chance to present this interesting topic, unusual presentations of thyrotoxicosis. And a big thank you to Dr. Shujai Ghosh. It was a pleasure working with him at IPJBR Kolkata. Thank you, sir. So I'll be sharing the screen. Just a difficulty in sharing the screen. I need a few minutes.
We can see your screen. If you could just share your PPT now, Riaz. We can see your screen.
Okay. Can you see the presentation?
Yes, we can just make it full screen.
This is okay?
Great.
Yes, sir.
Okay, let me start with this unusual presence of thyrotoxicosis. Outline of presentation is introduction, and we have chosen 2 cases from thyroid clinic. And then I will be spending some time on the unusual cardiovascular manifestations and a few slides on unusual manifestations of other body systems and concluding slides. Now, over the past few decades, there has been an increase in the number of unusual manifestations of thyrotoxicosis that are related to various body systems. These unusual manifestations may create a wide variety of differential diagnoses, and most of these manifestations have been reported in patients with Graves' disease, either due to the specific relation to autoimmune thyroid disease, or because of Graves' disease, as we know, accounts for the majority of hyperthyroidism cases. And sometimes one of the atypical manifestations is the main presenting feature of Graves' disease. And as endocrinologists, we have to be aware of these unusual manifestations to avoid delay in diagnosis, misdiagnosis, or unnecessary investigations. Let me start with the first case, a case of thyrotoxicosis with muscle weakness. So this 20-year-old female presented to the emergency room of our hospital with weakness of all 4 limbs, more in the lower extremity, so severe she could not stand. She also gave history of palpitations, restlessness, fatigue, and weight loss for 6 months. She had experienced intermittent cramps and mild weakness in the lower limbs over the previous 8 weeks. Examination in the emergency revealed tachycardia and anxious-looking female, fine tremor of tongue and hands, a grade 2 diffuse goiter. There was no orbitopathy or dermopathy. There was hyperpigmentation. Neurological examination revealed a profound proximal muscle weakness, more in the lower extremity. Deep tendon reflexes were normal. There was no sensory deficit. Investigations in the emergency revealed a hypokalemia, potassium of 1.6 and 1.9. The rest of the investigation in the emergency were normal. Then a referral to endocrinology department was sought, and this patient was shifted to our ward. In our ward, thyroid function revealed a high T3, high T4, and suppressed TSH, and anti-TPO antibody was positive. Further evaluation with us revealed a ultrasound thyroid revealed a heterogeneous echo pattern with increased vascularity, and a diffuse uptake was documented on a technician scan. So, in brief, we have a patient who has clinical and biochemical evidence of thyrotoxicosis, and in addition has muscle weakness. So what will be the differential diagnosis? Firstly, thyrotoxicosis per se can lead to muscle weakness, and this myopathy occurs to some degree in majority of patients with overt thyrotoxicosis, particularly in those patients who have a prolonged and untreated disease, and that's not uncommon on this part in this part of the world. A prospective study has shown that muscle complaints are very frequent in Graves' disease. It has been found in more than 60% of the patients, and it correlates with the free T4 levels and is not associated with creatine kinase elevations, and resolves after the treatment of thyrotoxicosis in an average of 3.6 months. The next differential diagnosis will be a thyrotoxic periodic paralysis. The third one, and again very important, will be myasthenia gravis. Myasthenia gravis disease occurs in about 3 to 5% of patients with myasthenia gravis. And if Graves' disease patients are followed longitudinally, 1% of these develop myasthenia gravis. The important is the myasthenic weakness is accentuated during the thyrotoxic state, and it improves when euthyroidism is restored. So are there some typical features of myasthenia gravis in the setting of Graves' disease? Yes, it occurs in patients for a younger age and is more likely to be associated with thymic hyperplasia. As we all know, thymic hyperplasia is Graves' disease is a well-known cause of thymic hyperplasia, and sometimes unnecessary surgeries have been performed in these patients. So in our ward, we made a diagnosis of Graves' disease with thyrotoxic periodic paralysis in view of clinical, biochemical, and imaging evidence of Graves' disease and hypokalemic periodic paralysis. Now, our patient in the emergency reception was started on oral and IV potassium replacement, which we continued in our ward. 6 hours after replacement, there was a marked improvement in the muscle weakness with normalization of potassium after 12 hours. We also started the patients on propranolol 160 milligram per day in divided doses and neomarcazole. Patient is on follow-up for more than 6 months, is asymptomatic with no further episodes of muscle weakness, is clinically and biochemically euthyroid, and the TFT at the time of last follow-up was normal. Now let us briefly discuss thyrotoxic periodic paralysis. It's an alarming and potentially lethal combination of hyperthyroidism, which is characterized by a triad of muscle paralysis, acute hypokalemia without total body potassium deficit, and hyperthyroidism. This is a disease of young Asian males. So most of the cases have been reported from India, Pakistan, Japan, and China. Now, TPP can occur in thyrotoxic of any cause. Most cases have been reported with Graves' disease, but all other causes can be associated with thyrotoxic periodic paralysis. Most patients with TPP have only mildly elevated thyroid hormone levels. Indeed, the hyperthyroidism may be clinically silent. So this is the catch in this hyperthyroidism may not be evident in many patients. The subtlety of the features of hyperthyroidism together with that this disease is rare, it makes TPP a difficult condition to diagnose at presentation. And Asian endocrinologists are more likely to diagnose this condition as compared to endocrinologists or physicians from the western part of the world, because the disease is very rare there. Despite a much higher instance of thyrotoxicity in women, this disease, TPP, mainly affects males. The attack is characterized by recurrent transient episodes of muscle weakness that can range from mild weakness, which improves of its own, to complete paralysis. The proximal muscles are affected more severely than distal. Respiratory muscles are seldom involved, but There are reports of total paralysis of respiratory, bulbar, and ocular muscles. In majority of the patients, the deep tendon reflexes are diminished, but patients may have brisk or normal jerks. Now, these patients develop hypokalemia due to the massive shift of potassium into the cells. There is no loss of potassium from the body. The urinary potassium loss is not there. Their urinary potassium excretion is normal or low, and the blood acid-base balance is normal. This is very important because sometimes, rarely, autoimmune thyroid disease can induce distal RTA that can also lead to hypokalemia and the weakness. So, degree of hypokalemia, it correlates with the severity of muscle weakness, but not the clinical features of thyrotoxicosis or thyroid hormone levels. In addition to hypokalemia, there may be hypophosphatemia and hypomagnesemia, but these aberrations, they return to normal once the patient recovers from the weakness. Replacement of potassium and magnesium is not needed. So what are the clues for the diagnosis of TPP? It's a young adult man, disease of young adult men, sporadic, recurrent acute paralysis with complete recovery, limb involvement more than truncal, precipitated by heavy carbohydrate meals. There may be a family history of hyperthyroidism. There may be clinical features of hyperthyroidism, hypokalemia, normal ABG, and low potassium excretion rate and low phosphate excretion. A similar presentation is by the disease FHPP, familial hypokalemic periodic paralysis. A resident in emergency or in neurology or in medicine is more likely to diagnose FHPP if he receives a patient who has paralysis, weakness, and has hypokalemia. So what are the differentiating points? TPP age group is 20 to 40. FHPP, it's in less than 20. As I highlighted, TPP is a disease of males, but in FHPP, there is no, it's equally found in both sexes. Hereditary, sporadic TPP, and FHPP is autosomal dominant. Patients with TPP can have family history of thyrotoxicosis, while patients with FHPP may have a history of hypokalemic paralysis in other family members. And of course, there will be no clinical features of hyperthyroidism in FHPP. So what are the precipitating events? Patients usually experience the attack after a few hours after a heavy carbohydrate meal or in the early morning. That's why most of these patients come to emergency room in the early morning hours. It is precipitated by ingestion of a carbohydrate-rich meal or alcohol. TPP occurs only in presence of hyperthyroidism, and it's abolished, it's gone when the thyroid hormone levels are normalized. Now, pathogenesis of this disorder is very interesting. Increased number as well as activity of the sodium potassium ATPase pump has been found in TPP patients with thyrotoxicosis than thyrotoxicosis without TPP. And when thyrotoxicosis is controlled, this activity of the pump returns to normal. Thyroid hormones increase the sodium potassium ATPase activity in the skeletal muscle, liver, and kidney. As we know, the skeletal muscle is the largest single pool of potassium in our body, and it plays a very critical role in maintaining calcium homeostasis, potassium homeostasis. And so there's an influx of potassium into the intracellular space. Not only this, catecholamines also increase sodium potassium ATPase activity. The hyperadrenal response in thyrotoxicosis further increases the sodium potassium ATPase activity, and this is the basis for role of beta blockers in this disease. Patients with TPP have an exaggerated insulin response during oral glucose challenge compared with thyrotoxic patients without TPP. And insulin again stimulates the sodium potassium ATPase activity and thus plays a permissive role in potassium shift. This hyperinsulinic response may explain the association with carbohydrate-rich meals. In the last decade, there have been very interesting findings in the pathogenesis of TPP. So as I was highlighting, on one hand, we have increased activity of sodium potassium ATPase activity, which is because of thyroid hormones, because thyroid hormones increase transcription of this pump, both by the genomic and non-genomic actions. Then we have a beta adrenergic stimulation and insulin.
Yes.
Yeah, continue.
I think we've lost.
Yeah.
So, Dr. Riaz.
There is
I think he's back. Yeah.
adrenergic stimulation and insulin also inhibit KIR 2.6. So on the basis of a genetic background of loss of mutation of this channel and these factors, so there is paradoxal depolarization, there is sodium channel inactivation and paralysis. Now, again, I want to highlight that this pump activity is increased by androgens, and this may be the basis that the disease is more common in males. The treatment in emergency room is potassium replacement with IV and oral, but we have to keep a close watch on serum potassium levels because rebound hyperkalemia is very common. Then propranolol is given 3 to 4 milligram per kg orally, and prevention of recurrent attacks is to avoid precipitating factors, educate the patient to avoid precipitating factors, and continuing with beta blockers. The beauty is once patient is made euthyroid, TPP does not recur. So adequate control of hyperthyroidism is the mainstay of therapy, and we have to plan our patients for definitive treatment. This again shows importance of making a proper diagnosis, of differentiating this as familial hypokalemic periodical paralysis, because the treatment subsequently becomes different. So learning points from this case, this is a rare condition, and the diagnosis at initial presentation is often delayed because of the subtleness of clinical pseudothyrotoxicosis and the similarity of paralysis with the more common conditions. Early diagnosis prevents serious cardiopulmonary complications. It is a curable disorder that resolves when euthyroid state is achieved. Now let us discuss now case 2. Is a 52-year-old female diagnosed case of Graves' disease who was doing well on carbamazole. She presented with a non-pitting edema, which is associated with indurated yellowish-brown plaques and nodules on the dorsum of feet. More was asymmetrical, more on the right side. The plaques and nodules, they were coalescing with each other. Examination also revealed a diffuse goiter and inactive orbitopathy. Now, she was doing very well on carbamazole, but what was these foot lesions were bothering her, and she had consulted few dermatologists who had given her local high potency glucocorticoids, but without any relief. So we diagnosed this patient with alphantasic pattern of thyroid dermopathy. Here we can appreciate their nodules, plaques, which have coalesced together. It's more in the right foot as compared to the left foot. See, thyroid dermopathy, which we cannot classify as the atypical presentation. But why we have chosen this case? Because the alphantasic pattern is exceptionally rare and it's very difficult to treat. So we decided to treat this patient with intralesional triamcinolone acetonide. Injections were given at multiple points. And this treatment was repeated monthly. After 6 months, a marked clinical response was achieved. We published this patient in the Indian Journal of Endocrinology and Metabolism. We can see the post-treatment picture. We can easily appreciate there is a marked improvement in the cutaneous lesions. Now, thyroid dermopathy, also known as pre-tubal myxedema, is an uncommon manifestation with an estimated incidence of 0.5 to 4.3%. It almost always occurs in association with Graves' ophthalmopathy, usually of severe degree. Thyroid dermopathy, it can be a presenting symptom of the disease, and it usually indicates a more severe Graves' disease. The typical site, as known, is pre-tubal, but upper extremity, shoulders, nose, face have also been reported. Its most common presentation is a non-pitting edema, followed by formation of plaques and nodules. And rarely, as was in our case, there was an alphantasic form, which is very rare. Now, the severe forms may cause functional impairment in the form of difficulty in wearing shoes, or can lead to entraped neuropathy, as our patient had started developing features of entraped neuropathy. Fortunately, dermopathy usually do not progress, and it may partially or completely regress. The treatment is local corticosteroid therapy, intra-regional injections, a decompressive physiotherapy to enhance the movement of lymph. Then systemic immunomodulation. The ophthalmopathy almost always it overshadows dermopathy. But if we give corticosteroids or immunosuppressor therapy for the ophthalmopathy, the skin lesions will also regress. Then there are case reports showing rituximab, octreotide, and selenium supplementation has a role in some difficult cases of thyroid dermopathy. Now, a few slides on the unusual cardiovascular manifestations. As you know, cardiovascular manifestations are one of the frequent manifestations in thyrotoxicosis like tachycardia, white pulse pressure, others. But over the last few decades, there have been a variety of unusual cardiovascular manifestations in patients with hyperthyroidism. This include pulmonary artery hypertension, right heart failure, myocardial infarction, heart block. Isolated right heart failure may be the presenting feature of Graves' disease. We have also previously reported a reversible heart block in a patient with Graves' disease, which reversed after treatment of Graves' disease. Now, what are the possible mechanisms of these cardiovascular manifestations? They may be immune-mediated endothelial damage or dysfunction, increased cardiac output resulting in endothelial injury, increased metabolism of intrinsic pulmonary vasodilated substances. The pulmonary hypertension as well as the right heart failure, that improves after treatment of hyperthyroidism, but it may take months for the improvement to happen. The other unusual manifestation, which I thought is interesting, is a Graves' disease anemia. So this is to be defined as an anemia not attributable to other causes. Like Graves' disease can have anemia because of pernicious anemia, iron deficiency anemia, celiac disease, autoimmune hemolytic disease. And this is supposed to be very common. There are few studies who have shown that it is found in 22% of the patients with Graves' disease. A brief mention of other unusual manifestations. Severe hypoproteinemia has been demonstrated in few case reports way back in 1963. Then chorea and hemiblismus. We are all aware that the tumor is a very common manifestation of thyrotoxicosis, but patients can have chorea and hemiblismus, which responds to beta blockers and resolves following treatment of thyrotoxicosis. Then pillular and pericardial effusions have been reported, not attributable to other causes, and the explanation given has been the immunological epiphenomena related to Graves' disease. A few concluding slides. The unusual manifestation of thyrotoxics are diverse and they involve various body systems. One or more of these unusual manifestations may be the presenting feature of Graves' disease, and we have to be aware regarding these to avoid wrong diagnosis or unnecessary investigations. The mechanism in many of these unusual manifestations remains uncertain, but we can conclude that the excellent recovery that occurs in response to restoration of an euthyroid. So once we make our patients euthyroidism, most of these unusual manifestations, they recur, but they may take some time. So this indirectly reflects that most likely all of these manifestations are because of excess thyroid hormone levels. There, at the molecular or cellular level, there may be different mechanisms, but how it happens actually, but the main culprit is the excess thyroid hormone levels. Thank you for your patient hearing.
Thank you very much. Dr. Bashir.
Thank you, Dr. Riaz. I really, although I had seen the presentation many days, but this time I really enjoyed the presentation. It was very good. At least there was a revision. So Dr. Riaz discussed the, a typical presentation is there was only one thing left which I forgot to discuss during last few days is the GI involvement. I remember many times we get calls from gastroenterology, a person is admitted with severe vomiting. So once the person is investigated, and other than thyrotoxicosis, there is no reason for severe vomiting. So no doubt thyrotoxicosis presents as increased appetite, but vomiting can be sometimes a feature. So with this, we have to keep in mind. And lastly is the thyrotoxicosis presenting as liver disease. This is a double-edged sword because liver disease could be because of thyrotoxicosis, or liver disease could be because of the treatment, drugs. Drugs, we know both these thiazide can cause, some cause more hepatocellular damage, some cause more cholestasis. And once person with thyrotoxicosis on treatment develops jaundice or hepatitis or cholestasis, and we are actually scared that time, and then we try to look for alternative options. So there's a small possibility that it could be because of thyrotoxicosis as such. So then last, actually, sometimes this is a very rare presentation, the case which we have published in endocrinologist, that case. We saw a patient of thyrotoxicosis was referred to us. Once this patient had a high T3, T4, clinically looked toxic, she was sent for endoscopy. I don't know, remember this time why, and she developed severe hypertension that time, hypertensive crisis. Then once she came back, we investigated and we found that her BMA was high and metanephrine was high. Further investigation revealed that she had bilateral adrenal masses. So it was a bilateral pheochromocytoma presenting as thyrotoxicosis. In between, she did not have any hypertension. So ultimately, we treated pheochromocytoma. This is important because once we suspect thyrotoxicosis, first thing to start is a beta blocker. So rarely we can have a pheochromocytoma if we start with a beta blocker. So this may be a catastrophe. So once we treated this patient, surgery was done and thyrotoxicosis went into remission. So these are 2-3 cases which we have published, and this we shared our experience of typical presentations with the this thing seen in patients with thyrotoxicosis. So I think we have spent enough time. If there are any questions I would like to take, then it's 8:34, so another few minutes.
Right. I think we should thank both of you for that wonderful duologue of interesting cases. I can remember from the top of our head that, sometimes you need to investigate even patients of hypercalcemia and check their thyroid functions. People with osteoporosis and check their thyroid functions. Those are some of the other relatively rarer complications or presentations of thyrotoxicosis. Dr. A.P. Bhatia from Delhi, he's asked a question to Dr. Riaz. Can thyrotoxic periodic paralysis occur due to overdose of levothyroxine sodium?
Due to overdose of?
Levothyroxine. So somebody maybe is hypothyroid, was on levothyroxine sodium, you've over-replaced. Could that lead to thyrotoxic periodic paralysis?
Yes, so that will be sort of an iatrogenic thyrotoxicosis if we are giving an overdose. And any, as I highlighted, any form of thyrotoxicosis, right from Graves' disease to iatrogenic, can lead to a periodic paralysis.
Right. So today we've learned quite a few things that, we need to be vigilant about clinical presentation of individuals when you are thinking of thyroid disorders, particularly thinking of overactive thyroid disorders, whether we are talking about cardiovascular disorders presentation, whether we are looking at skin presentation, whether we are looking at neurological presentation. And like I mentioned, it could be even electrolytes like calcium, osteoporosis, GI symptoms. I think a lot of so-called irritable bowel syndrome ultimately land up as thyrotoxicosis. So those are the subtle and even psychiatric disorders. Depression in the elderly can be because of thyrotoxicosis, even though we say anxiety, agitation are more important presentations of thyrotoxic disorders. So because thyroid hormones almost act on every organ system, we need to be vigilant about the possible subtle effects of excess thyroid hormones. So anytime you look at someone with any atypical presentation, you try to figure out whether the thyroid is the cause of it. And Dr. C.M. Batra from Delhi, he has also asked a question on whether there are any reports of genetic studies of thyrotoxic periodic paralysis. Because, hypokalemic periodic paralysis is associated with several channelopathies. So he's asking whether the thyrotoxic periodic paralysis is associated with genetic studies.
Yes, as I discussed in my presentation, the KIR 2.6 mutation, it has been found in most of the patients, 2/3 of the patients with a thyrotoxic periodic paralysis. And there have been different mutations from different parts of the world, but it has been well documented and is now in textbooks also that KIR 2.6 mutation, along with the increased activity of the sodium potassium ATPase, they work together and lead to the pathogenesis of this disorder.
Thank you so much. Sorry, Doctor.
There have been some HLA associations noted with this. But one interesting thing which I found from Delhi to Srinagar is that in Delhi, we would mostly see these patients from Northeast. And in Srinagar, we mostly see these patients from Ladakh, Leh Ladakh. So this disease is more common in this sort of a race. So what is the pathogenesis? What are this thing? Nobody knows, but associations have been seen.
So once again, I would like to thank Dr. Bashir and Dr. Riaz for an excellent session and hand over to Dr. Arun for the next session and introduce the next speaker.
Thank you, Dr. Sujay.
Thank you very much. My pleasure.
Thank you very much.
Thank you, Dr. Sujoy. Thank you, Dr. Bashir and Dr. Riaz. So we now move on to the next session, which is the most awaited session by the delegates always. There's a lot of postgraduate trainees are there. They're always very keen to participate in the quiz. And to conduct the quiz this evening, we have got a young endocrinologist, Amir Joshi, who is very well known to many of you. He's actually the director of diabetes and endocrine clinics in Mumbai. He has already won several awards in his young career. He's currently the secretary of Maha Endocrine Society. He was the ESICON scientific secretary in 2019. So over to you, Amir, to conduct the quiz. And we all look forward to this session.
Yeah. Thank you, Team Indian Thyroid Society, Dr. Sarita Bajaj, Madam, and Dr. Riaz Dr. Arun for giving me this opportunity. And it was great to see old friend Riaz after a long time.
Thank you.
So also everyone. I would just request that I was briefed that the organizers will be announcing some rules of the quiz before we start. Yeah. So quiz participants should answer the quiz using 4 options: phone as well as laptop. The case or description will be shared on Zoom screen by the quiz master. So I'll be sharing the questions or scenarios with 4 options, and you are supposed to answer the most appropriate option.
Sir, first we start with the dummy questions,
Yeah.
2 dummy, and then we go with the actual quiz.
Yeah, please go ahead. Please take over.
Can we have the dummy question to start with?
I think you need to read that out, Amya.
Yeah. So the first question is official language of India is, and it's a single choice question with the options being A, Bengali, B, Marathi, C, Hindi, and D, Tamil. The second dummy question is, who is the father of nation of India? And the options are A, Bal Gangadhar Tilak, B, Mohandas Karamchand Gandhi, C, Jawaharlal Nehru, D, Subhash Chandra Bose. And you have to click the single best answer and submit your response.
The first question is incorrect. There is no official language of India, in spite of what the propaganda is, as if Hindi is
I agree
the
with that. Last time we decided to change it, but somehow the digital team didn't get hold of that. Pakka it'll change next time.
Yeah. So I'll be sharing the questions.
Okay, sir, we'll launch the actual quiz.
Okay. Should I be sharing my screen?
Yes, sir.
Yeah. Yeah. So let's start with question number 1. Had a thyroid cancer and he underwent a surgery, after which he had a successful surgery, survived to live a normal life, and died from causes other than that of thyroid cancer. He happened to be a famous writer, and he wrote a memoir, and in that he stated, the operation gave me occasion to prove how delightful it was to be a writer. Carl, the doctor, charged me $1,500 for the operation, well worth it. And I later wrote up a funny article about it, including my title verse, and charged $2,000 for the piece. Haha. And how do you like that? You medical profession, you. That's the irony of medical profession. We all know that. But you have to identify the person. And your options are A, Isaac Asimov, B, Mikhail Gorbachev, C, Rod Williams, and D, Gigi Hadid. We move on to our next question. And this takes you to the clinic room. There is a 32-year-old lady who presented to the OPD with a thyroid nodule, and she was euthyroid. She was sent for a thyroid ultrasound. The sonologist did not report it via TIRADS, and the report came to you. The report read 2.5 centimeter nodule with mixed cystic, isoechoic, wide than tall, lobulate, with peripheral rim of calcification. What you are supposed to identify is how many points you will give and what will be the category you will put it in. The answer are 3 points, level TIRADS 3, B, 4 points and level TIRADS 4, C, 4 points and level TIRADS 4, and D, 8 points and level TIRADS 5. We all adore TIRADS, or what we call it as ACR TIRADS. But let us look at what could be one of the most important limitation of ACR TIRADS. And the options are A, it does not consider the size of the nodule. B, the echogenicity of the nodule is not considered. C, lymph nodes are not considered. And D, calcification is not considered. From sonography to further, a 66-year-old gentleman undergoes evaluation of a 2 centimeter thyroid nodule, and it yields an FNAC report of Bethesda stage 4. So he's in a big dilemma whether he should be going with a surgery or not, and he's not keen on that. So he decides to undergo an Apharma GEC testing, and the same is negative. So does it ease out his dilemma? What would you counsel him? What will be the risk of malignancy in his case? So the question is, what will be the risk of malignancy in his case? Will it be less than 1%? Will it be 1 to 5%? Will it be 5 to 15%? And will it be 15 to 25%? I repeat, 66-year-old man, NSC showing Bethesda stage 4. He undergoes Apharma GC testing and the same is negative. You have to look at the risk of malignancy, and options are A, less than 1%, B, 1 to 5%, C, 5 to 15%, and D, 15 to 25%. You have to identify a gene which is not associated with invasive thyroid cancer. Nowadays, we have a facility to get clinical exome sequencing, and we are not that routinely still getting for differentiated thyroid cancers, but definitely for medullary thyroid. So what we need to do in this case is look at the genes that are given to you and identify the one which is associated with differentiated thyroid cancer risk, but not associated with invasive thyroid cancer. And the options are A, RET proto-oncogene, B, Dicer1 gene, C, BRAF gene, and D, NTRK gene. Use I-131 for iodine scan and iodine therapy. But there is another isotope, I-123. And we have to identify in which particular scenario you may be tempted to use I-123 where it fares better than I-131. Is it better for therapeutic? Is it less expensive? C, is it good for visualization of retrosternal tissues and offers a better image quality? And D, all of the above is correct. Now, question 7. A 37-year-old male presented to the emergency department with a blood pressure of 80/60, was having giddiness. On examination, he has cervical lymphadenopathy and is pigmented. His history reveals that he has retroviral disease and has defaulted from antiretroviral therapy. The reports show a sodium level of 122, potassium level of 5.6, a random sugar of 68, a random cortisol of 4, and a TSH of 15.6. The thyroid peroxidase antibody is done, and that is negative. So what will be the most appropriate next step? And I'll give her a clue that this question finds a root in a case published in Thyroid Research and Clinical Practice. So option A, will you start hydrocortisone and follow up with thyroxine after 3-4 days? Will you be starting both thyroxine and hydrocortisone? Will you go, that's option B. The option C is, will you estimate antithyroglobulin antibody? Or option D, will you reassess the TSH level after stabilization? I'm sorry that I did not mark option B, C, and D, but option A is start hydrocortisone and follow up with thyroxine. B, start both thyroxine and hydrocortisone. C, estimate antithyroglobulin antibody. And D, reassess TSH levels after stabilization. Now, there are various symbols in thyroid, symbol of thyroid awareness, symbol of thyroid cancer awareness, and this is the symbol of thyroid cancer awareness. This is a 3-colored ribbon, and you have to identify who designed the symbol. Is it A, Leonard Wartowski, B, Susan Mendel, C, George Bush, and D, Cherry LC. Moving to the therapeutics at the horizon, and one of the most challenging areas has been waves ophthalmopathy. And the molecules VRDN-001 and VRDN-002 are antibodies in pipeline for thyroid eye disease. and you have to identify their mechanism of action. Are they TNF alpha antagonists? Are they IGF-1 receptor antagonists? Are they TSH receptor blockers? Or are they anti-CD20? I repeat, you have to identify the antibodies VRDN-001 and VRDN-0002, which are in pipeline for treatment of thyroid eye disease, whether they are acting by as A, TNF alpha antagonists, B, IGF-1 receptor antagonist, C, TSH receptor blocker, and D, anti-CD20. Question 10. Some of you might be knowing this gentleman. Some of you may have seen him. You have to identify this scientist who is known for his work in the field of thyroidology. Is it Dr. MMS Ahuja A, B, Dr. S.D. Bhandarkar, C, Dr. Krishna Chatterjee, and D, Dr. Kochupille? I think the questions end here.
Yes.
And maybe I hand over to the digital team. Yeah.
Thank you. So
Yeah,
we'll have
thank
the
you, ma'am.
answers at the end of the. Over to you, Arun.
Thank you, ma'am. Yeah, thank you, Ameya. That's really stimulating questions. I'm so happy that I don't have to answer as the organizers. Wonderful. So look forward to the answers in the end of the session. So we move forward and we have the next session, which is a monologue. And to introduce the speaker and the topic, let me once again request Dr. or Professor Sujoy Bosch to take over and introduce the speaker and the topic. Sujoy, please.
Thank you very much once again. A very interesting set of questions in the quiz, as usual, by brilliant Ameya. Now, moving on to the next session, it's a pleasure to introduce Dr. Shanmuga Sundaram. He's head and professor, Department of Nuclear Medicine and Molecular Imaging at Amrita Institute of Medical Sciences, Cochin. He has several qualifications, including DRM, DNB, MNA, MS, and FANMB. His area of interest is nuclear oncology, thyroidology, and cardiology. He's been part of the Association of Nuclear Medicine Physicians of India, has several awards to his name, particularly multiple travel grant awards, and he has published close to an incredible 150 papers. And he's going to talk to us upon something that we clinicians see quite commonly in day-to-day clinical practice: tennis. That is, we see when we are following up our patients of thyroid cancer, it's common practice to check the thyroglobulin level along with the anti-thyroglobulin antibody levels. And we find that there is a rise in the thyroglobulin level, whether it's a gradual or an abrupt one. And as part of protocol, we would then ask for a iodine scan, and often the scan does not reveal any localized lesion. Now, what do you do in such clinical circumstances? That is the clinical problem that he's going to talk to us. Over to you, Dr. Professor Sundaram.
Thank you, sir. Good evening, everyone. At the outset, I like to thank Dr. Arun and ITS team for giving me an opportunity to be part of this program. It's my pleasure to be discussing this highly clinically relevant and very interesting topic: tennis, a diagnostic and therapeutic challenge. I hope my screen is visible, Dr. Arun.
Yes, it is. Yes, it is. Please go ahead, Shanmuga.
Thank you. So in the next 20 minutes or so, we shall be discussing what exactly is tennis, the uniqueness of tennis, how we have to evaluate tennis, what are the investigations we perform, how to manage this vexing problem, tennis, and let us see some case examples from our day-to-day clinical practice. So tennis is thyroglobulin elevated negative iodine scan syndrome. And it is unique because we see it only in follow-up cases of differentiated thyroid cancers who had thyroidectomy followed by most of the time residual thyroid ablation or a metastasis iodine 131 therapy. Significant increase in incidence of tennis is happening now. The literature reports around 15%. And even in our day-to-day practice, most of us agree it is around 15 to 20%. To simplify tennis mechanism, it is the loss of function mutation in thyroid follicular cell. Thereby, there is sodium iodide symporter function is lost. What is the implication of this loss of sodium iodide symporter function? There is no I-131 concentration in differentiated thyroid cancer follicular cells. Thereby, there is no I-131 uptake in iodine 131 diagnostic scan. But we know these patients' thyroid follicular cancer cells have preserved thyroglobulin production. So there is flip-flop phenomena occurs in the nuclear medicine imaging. The flip-flop typically is explained by the fact there is significant differentiation of thyroid follicular cells. So thereby there is a good uptake of I-131. It happens that we don't use 18F fluorine labeled deoxyglucose PET because fluorine gets concentrated, the deoxyglucose gets concentrated only in undifferentiated thyroid follicular cells. But in tennis, exactly the flip-flop happens. The I-131 scan, when it becomes negative, the fluorodeoxyglucose positron emission tomography scans become positive. So the flip-flop phenomena occurs due to the loss of function mutation in thyroid follicular cells, thereby the functional loss of sodium iodide symporter. There is a subtle but important difference between tennis and I-131 refractory differentiated thyroid cancer. It cannot be interchangeably used. One of the causes of or one of the reasons of I-131 refractory DTC can be tennis, but all the tennis syndrome patients need not be always be I-131 refractory. The radioiodine refractory differentiated thyroid cancer is defined in many ways. Some of the common ways are the presence of at least one lesion not taking up I-131. Lesions previously taking up I-131 now have become I-131 non-concentrating. Some lesions take up I-131 and some lesions are not taking up I-131. I-131 is not providing any clinical benefit in spite of there is a good I-131 uptake. And the last one, the cumulative dosage of I-131 has exceeded 600 millicurie. So these are the definitions of radioactive iodine refractory differentiated thyroid cancer. So tennis is to be differentiated from this clinical condition. One of the important false positive of I-131 scan is the poor preparation of patients. So they should, before branding a patient as a real tennis patient, these are the things we need to rule out. One is the poor patient preparation, where patient has not followed a iodine-free diet. Thereby, there is saturation of the iodine body pool with non-radioactive cold iodine. Thereby, there is no uptake of radioiodine. So this has to be definitely to be ruled out before calling a patient as a true tennis patient. The tennis-like situation or the negative iodine scan can happen because of too small dosage of I-131. Normally for follow-up of I-131 differentiated thyroid cancers, the I-131 dosage should be somewhere around 4 to 5 millicurie. The usage of tracer, although I-123 iodine tracer is not available in India. It is one of the ideal tracers for diagnostic scan, but unfortunately we can't do that in India. And the influence of anti-thyroglobulin antibody. The high anti-thyroglobulin antibody or presence of heterophile thyroglobulin antibody showing a falsely increased thyroglobulin. So the scan is true, but there is a false rise in thyroglobulin. So these 4 conditions are to be ruled out before calling a patient as a true tennis patient. Normally, we consider tennis in a patient where the scan is negative, I131 whole body follow-up I131 scan, and with the stimulated thyroglobulin, which is more than 2 to 10 nanogram. So how to investigate this patient? Once a true tennis patient is identified, the easiest, the most productive and most cost-effective investigation is a simple ultrasound neck. It has a good specificity, even though it lacks poor sensitivity because of its lack of ability to identify level 6 nodes and mediastinal disease. Still, ultrasound should be the first line of investigation. Previously, people used to do a high-resolution CT chest mainly to look for pulmonary nodules, but it is now largely replaced by a whole body 18-fluorine labeled deoxyglucose PET CT, because you get the information both from the CT and also the uptake of fluorodeoxyglucose. Whenever we consider the patient for doing whole body 18 fluorine labeled deoxyglucose, patient should be off thyroxine, and the sensitivity of this scan increases with rising TG level. This is a literature evidence. Whenever you have less than 10 nanogram, you have a sensitivity of only around 11%. But if there is an increase in the thyroglobulin level, when it is more than 100, you have 93% sensitivity. The fluorodeoxyglucose PET scan can also be used for prognostication. The higher the FDG uptake, shown by the higher standard uptake value, and higher the number of FDG positive lesions, the poorer the prognosis. That means there is more of dedifferentiated thyroid cancer follicular cells, and obviously their prognosis is less. On the same way, the survival, there is a definite survival difference between less than 125 nanogram thyroglobulin and more than 125 nanogram thyroglobulin. So whenever you have a higher thyroglobulin, obviously there is widespread disease and more diffuse or systemic disease which cannot be taken care by a curative surgery. So this is a simple algorithm which has been described in the tennis. Most of the time you start the investigation with a neck ultrasound. And if the neck ultrasound is non-contributory, you can straight away go for a fluorodeoxyglucose whole body PET CT. And if the PET CT, according to the findings in the whole body PET CT, fluorodeoxyglucose, you can decide whether it is an operable disease or an inoperable disease. And based on that, you will go for a curative surgery or with other systemic mode of treatment. So obviously the management of tennis is directed by these 2 basic investigations, ultrasound and fluorodeoxyglucose whole body PET CT. And whenever we identify localized disease in the form of neck lymph nodal deposits or mediastinal lymph nodal deposits, then you can always think in the terms of a radical surgery, which is going to be a resectable disease. But when you identify systemic disease, when you have systemic disease by the fluorodeoxyglucose, like the lung deposits or skeletal deposits, obviously it is going to be a systemic therapy. When PET doesn't identify any lesion, the ultrasound is negative, the whole body fluorodeoxyglucose PET CT is also negative, then there is a role for empiric radioiodine therapy. This empiric radioiodine therapy conventionally is done with 100 millicurie. People can have used a dosage of 200 millicurie, but in our day-to-day practice in our center and most of the Indian centers, we use 100 millicurie as the dosage for empiric radioiodine therapy. Is it very effective or not? The literature evidence is there for the systemic therapy of radioiodine as an empiric modality. There is a 63% reduction in 63% of patients. There is a reduced thyroglobulin after the empiric radioiodine therapy, and the post-therapy scan, immediate post-therapy scan, normally done after 72 hours to 96 hours of the radioiodine therapy. As high as 57% of patients show a diffuse disease, most of the time the pulmonary disease. So this empiric radioiodine therapy has been found to be very effective when there is a rapid rise in thyroglobulin, that is the doubling time of thyroglobulin is very less, and these are the patients who are benefited by empiric radioiodine therapy. Having told that, empiric radioiodine therapy is not always universally accepted. Many of our nuclear medicine colleagues differ from these data and they don't use empiric radioiodine therapy. But in my personal view, empiric radioiodine therapy is a very effective way of treating the patients, especially when the ultrasound and fluorodeoxyglucose whole body PET CT are negative. So how we manage this systemic disease? Most of the time, these patients are managed with an empiric radioiodine therapy, and there is a role for external radiation. External radiation, most of the time, is for tumor mass in the neck, where there is a recurrence with a significant tumor mass, where the surgery is not feasible. And external radiation is an effective way of treating painful bone metastasis. They can be treated either with a empiric radioiodine therapy or an external radiation, sometimes by embolization or a radio frequency ablation. Obviously, we have found significant clinical benefit by using pamidronate or zoledronate injections, and vertebroplasty or kyphoplasty are rarely performed. Coming to the investigational treatment approaches, there are some specific modalities of therapy in tennis which are considered as investigational. Number one is molecular targeted therapy, most of the time with tyrosine kinase inhibitors, and people have a good experience with sorafenib and presently lenvatinib. Lenvatinib has been found to be more effective for the management of systemic tennis patients. Although there are a lot of discussions on redifferentiating agents, personally we have never used redifferentiating agents, but the concept is good, where you reactivate the sodium iodide sympathus and you will have a significantly high thyroglobulin synthesis, and also there will be a high iodine 131 uptake. Possibly the gene therapy, where you are restoring the p53 tumor suppressor gene, will be the ultimate goal of any clinician in the management of tennis. But right now we don't have an access to gene therapy. That's where one of the investigational therapy is of our interest, that is the lutetium dotatate therapy. It is basically a somatostatin receptor targeted therapy. So whenever you have a gallium dotatate gallium dotatate PET CT, if it is positive, where you are able to demonstrate the presence of somatostatin receptors in the thyroid residual or recurrent primary lesion and metastatic lesions, then you can think about this investigational treatment, that is lutetium labeled 177 pure beta lutetium labeled dotatate somatostatin receptor systemic targeted therapy. So this is a nice, again, a simple algorithm where you do a systemic study with the gallium dotatate scan. And if it shows the presence of systemic somatostatin receptor positivity in these lesions, then you will go ahead with the PRRT or peptide receptor radionuclide therapy with lutetium dotatate. If it is negative, then you will consider the other investigational modalities. So what is the present status of this peptide receptor radionuclide therapy? Nuclear medicine physicians talk a lot about the peptide receptor radionuclide therapy. It has to be kept in our mind. It is again an investigational therapy modality. but possibly there is a potential role for this. This is a latest BMC cancer review article where there is they have collated all the data on the systemic PRRT, and we have around 157 patients who have been treated with PRRT. Majority of these patients are radioactive iodine resistant or refractory DTC patients, and they have shown partial or complete objective response and biochemical response, and this is a lesser percentage only. The objective response was seen only in 10% of patients, and a biochemical response was seen in around 25% of patients. But at least we take the thing that there is fewer and milder side effects. There is less than 10% of patients showed only side effects, which are much fewer and milder. So this may be one of the potential therapy modalities which can be considered in these tennis patients. So next 3 minutes to 4 minutes, so let us see 3 or 4 case examples. So this is a typical tennis patient, 43-year-old male with presenting with differentiated thyroid cancer and lymph nodal metastasis. Patient underwent the total thyroidectomy and modified radical neck dissection. Patient was treated with 100 millicurie of I-131, and this is a follow-up scan 6 months later showing negative iodine scan, but with a thyroglobulin of 126 nanogram. You can see there are multiple lymph nodes, mainly in the cervical and also in the mediastinal nodes. The cross-sectional imaging clearly shows that there is residual disease in the thyroid bed, left level 4 node, and also the mediastinal nodes. Although this particular patient has only localized disease in the form of lymph nodes, these lymph nodes, you can see they are tiny, too tiny, only millimetric nodes, only 2 millimeters, 3 millimeters. So even in the best hands of the head and neck surgeons, it is too difficult to be removed, and the matter is complicated with these mediastinal nodes. So we have treated this patient with 1 sitting of empiric radioiodine therapy, and possibly we will definitely consider this patient for a resurgery when the size of these lymph nodes become more, and obviously this patient may not be benefited by this empiric radioiodine therapy, but as an interim measure we have done this. The second patient, this is a much more sinister patient in the form of negative iodine scan. The thyroglobulin is 1246 nanogram, and you can see multiple lesions both in the neck, the mediastinum, and even the skeletal metastasis. So this is the patient who will have a very poor prognosis and has to be treated only with possibly with an investigational modality of therapy. So this is a patient who will be the curative intent patient, where the iodine 131 scan is negative, and iodine 131 scan, even though it is negative, we are able to very clearly show the residual disease in the form of thyroid bed lesion, and also, thyroid bed lesion, and also level 3 and level 4 nodes. You can see the negative iodine scan, but there is focus of abnormal FDG uptake in the left level 3 and left level 4 node. So these nodes are fairly large, around 1 to 1.2 centimeter. So patient will be immensely benefited by a curative intent radical neck dissection, and that's what happened to this patient. And after that, the thyroglobulin of 176 have come down now to 10 nanograms. So this particular patient was immensely benefited by a radical surgery. So this is a typical empiric radioiodine therapy patient where the negative iodine scan and the FDG PET also was negative, and our patient was treated with 1 sitting of empiric radioiodine therapy. 100 millicurie was given. You can see there is a diffuse increased uptake in the bilateral pulmonary fields in the immediate post-therapy scan. The TG of 600 nanogram has come down with 1 sitting to 200. So we intend to treat this patient with next sitting of radioiodine. So to conclude, tennis syndrome is a diagnostic and therapeutic challenge. The ultrasound neck and fluorodeoxyglucose whole body PET CT are the investigation of choice. We have surgery as a curative intent and possibly radioiodine therapy as a curative intent management tools. But investigational therapy role, even though not established, is to be considered in patients with systemic disease. We should develop more interest towards the possibility of using lutetium dotatate as a potential systemic therapy. And ultimate therapy should be the gene therapy. So till then, the lenvatinib will be the last resort as a tyrosine kinase inhibitor. Thank you very much for your patient hearing.
Thank you for an excellent lecture, Professor Sundaram.
Thank you, sir.
You have very, very lucidly summarized the basic clinical issues in the diagnosis and management and workup of tennis. Now, there are several questions from Dr. C.M. Batra. He's asked quite a few questions, and I'll try to rearrange the order of the questions that he's asked. The first being quite a common question is that post-surgery, we often tend to do a 5 millicurie scan. Now, can that itself cause stunning before subsequent radioiodine? That's question number one. The second thing he's talked about is a case of papillary thyroid carcinoma, 2 centimeters. He's not talked about the other issues in terms of the Massis score or any of the other scores. 12 out of 23 lymph nodes positive. The individual has had a thyroidectomy, and post-surgery, the thyroglobulin unstimulated was less than 0.2, and then a whole body iodine 131 scan after thyrogen shows no uptake at all. How to treat? I have to admit, my patients can't afford thyrogen. Over to you, Dr. Sundaram.
So the first question is, yes, absolutely right. We are very conscious of how much amount of radioiodine we use, but the theoretical or the practical issue of stunning happens mainly in the immediate post thyroidectomy setting, where you can expect significant amount of residual thyroid tissue, and there we always limit our dosage of radioiodine, especially I-131 when you are using, to less than 2 millicurie. But when you have to do a follow-up scan after 6 months or as an yearly follow-up, the dosage of radioiodine cannot be definitely more than 5 millicurie, but it cannot be less than 3 millicurie also, because you need some amount of radioiodine to be given for the minimal amount of residual thyroid tissue and functioning thyroid metastasis that will be, if at all anything is present, because here there is no residual thyroid tissue. So obviously the amount of radioiodine that is to be administered cannot be less than 5 millicurie. And I think in this present clinical setting of post-radioiodine ablation or post-thyroidectomy, post-radioiodine ablation, we don't really need to worry about the stunning part, and we normally use 4 to 5 millicurie. In our institute, we always use 4 millicurie as a standard dose. So I think it is accepted. It should never be beyond 5 millicurie. That is the first good thing. Second is, you told, sir, patient underwent thyroidectomy, but 12 out of 23 nodes were positive. So obviously patient had a neck node dissection also. So in that particular setting, first thing I will check out is whether patient has really stopped whether patient has really followed iodine-free diet. So in spite of the fact that they may have used thyrogen will increase the TSH. Yes, true. But it is not going to take care of the iodine body pool. So it has to be emphasized that patient has to follow the iodine-free diet at least for 2 weeks, especially in our place, the Kerala being a coastline, the primary food that they take every day, they take fish. So obviously the non-vegetarians is going to have a very tough time. So we need to have this particular instruction being made to be followed by the patient at least 2 weeks. In our center, we make them, in spite of the fact that we are going to use thyrogen in some specific indications, we make the patient at least to follow 2 weeks of dietary preparation. Probably that is the main reason why the iodine scan was negative. And at that point, when we are giving Thyrogen, I will also be doing a serum thyroglobulin. Probably that will be the more identifiable or more clinically oriented, disease oriented serum thyroglobulin. Obviously, that may have to be more in this particular patient.
Right. I hope that answers Dr. Batra's question.
Even if the next scan is negative, in that particular patient, I think we have to consider empiric radioiodine therapy because 12 out of 24 nodes are positive. So yes, I like to have a diagnostic scan positive before I am doing a therapy. But even otherwise, I personally feel in that particular patient, we should go ahead with one sitting of radioiodine, possibly with 100 milligrams.
Right. Dr. Batra adds that the patient had followed iodine-free diet for 3 weeks. Right. Okay. I think all good things must come to an end. If there are no further questions, I would actually have to hand the session back to Dr. Menon and then Ameya to declare the results of the questions that he's asked and then the results of the quiz.
Thank you, Shanmuji, for a wonderful lecture. Thank you, Sujoy, for moderating this session very well. So now it's back to Ameya. He's going to enlighten us on the answers to the quiz questions. Please go ahead, Ameya.
Yeah. Thank you to all the participants who attempted the quiz, and I hope it added some perspective. Yeah, so the first answer is Isaac Asimov, the writer who had a thyroid cancer, went on to give a memoir saying that he actually charged more to write the article rather than the surgeon doing a surgery. The answer to the second question, where we discussed about the lady whose thyroid ultrasound showed a nodule with the description, is 6 points and level TR4. I must say that at times you get radiology centers which still have not adapted a TIRADS, and it's a good practice to learn thyroid sonography as well as have TIRADS calculator that you can even look at the photo of the nodule and give your own TIRADS score. There is a TIRADS calculator website, and if you have done little bit training in thyroid ultrasound, you can do it yourself even looking at the images. And our patient's nodule falls in answer C, 6 points level TR4. We all have shifted to ACR TIRADS, but it has some limitations. And one of them is C, lymph nodes are not considered. So the answer to question 3 is C, lymph nodes are not considered. One more limitation of ACR TIRADS is the lack of respect given to the vascularity, which at times can be tricky. This is just the ACR TIRADS chart, and maybe you can keep this or have a TIRADS calculator. Now, the molecular biology testing is not yet easy in India. And though they have representatives, the charges are still to the tune of 1.2 to 1.3 lakhs, depending on the rupee dollar fluctuations. But what an Apharma GEC tells, in a stage 4 Bethesda stage, if it is negative, you can reclassify the nodule as Bethesda stage 2, or a malignancy risk is 1 to 5%. And you can follow it up like a Bethesda stage 2. And a 66-year-old man may actually not want to undergo a surgery, which is the decision that he took. As things economize, we hope that these tests are also available to us at an economical price. The fifth question was regarding different genes, and we spoke about clinical exome sequencing, and maybe 10 years down the line, every malignancy patient will have his CES done. And we talk about different genes. The red proto-oncogene we know about medullary thyroid cancer, BRAF and NTRK are all associated with differentiated thyroid cancers. One of the peculiar thing about the answer B, that is DICER1 gene, is that it does not cause invasive thyroid cancer, whereas BRAF and NTRK cause invasive thyroid cancer. I-123 is better for visualization of retrosternal tissues and offers a better image quality, but definitely is more expensive. So used in selective conditions. Now, this was a wonderful case published by Dr. Rajesh Rajput sir and his team. I had tweaked it a little bit, but it was about fact that the TSH level can rise in somebody with Addison's disease. And the clinical picture was clearly of an Addison's disease. We expect a rise up to 8, 10, or 12, but this case showed the TSH up to almost 15, which normalized after starting the glucocorticoid replacement. And so the correct answer is D. You will reassess the TSH levels after stabilizing the patient. This symbol of thyroid cancer awareness, the 3-colored ribbon, was designed by Cherry LC, who herself was a thyroid cancer survivor and an active part of a patient support group. So the answer is D, Cherry LC. We just had something which acts on a similar mechanism, getting a US FDA approval for thyroid eye disease. But there are more molecules in pipeline, and BRDN 0001 and 0002 are basically IGF-1 receptor antagonists, which are being studied for thyroid eye disease. And the gentleman, those who are interested in genetics of thyroid hormone resistance may have guessed it right. It's Dr. Krishna Chatterjee, answer C. Can we have the actual results of the quiz, tech team?
You can do the honors, Amya, announce the winners.
So the quiz winners are Dr. Sumaya Abdul Kalam, Dr. Sanjay Srivastava, and Dr. Raja. I hope we could know where these 3 wise doctors come from, and a personal as well as on behalf of ITS, thumbs up and congratulations to them.
Thank you, Amaya. That's true. I think we should also know where they are from, isn't it? That would have been nice. I'm sure they're all will turn out to be very efficient technologists in times to come. So thank you so much, Amaya. That was a wonderful quiz. Thank you.
Pleasure.
I see that Dr. Pramila Kalra, our scientific chair, is with us. For last words from Pramila and from ma'am, I suppose we can conclude the session. Over to you, Pramila.
Yeah, I think it was very interesting as usual, because most of our thyroid clinics are now widely, our residents are very liking it too much, because today evening one of my resident actually asked, "Madam, you forgot to send the link to me." So I said, okay. So it's quite interesting for the students, and students are actually appreciating it and liking it, because we all learn a lot, students learn a lot from all this. So I hand it over to Madam to say her final words.
Thank you, Pramila, for those kind words. Of course, I think everybody should know that all these thyroid clinics are available on our website. So if they're not able to attend the whole session, or they have not attended earlier sessions, then they can visit our website and access all of them. Even the quiz is there. So you can always, try taking a test for yourself and see where you are. I think between Dr. Misgar and Bashir, they made an excellent presentation. The wide spectrum of the unusual features, and I was absolutely fascinated by that elephantiasis like photograph that they show, and it's extremely rare. When we talk of dermopathy, I mean, honestly, I have really not seen a case till date. So that is the honest truth. I'm not sure what Ray's will say in that context, but if they've seen it and they've diagnosed it, that's really great. And of course, Dr. Bashir, he added his comments regarding the GI manifestations. So there we are. Ameya's, like I think Sujoy said, that he's brilliant. And there is the quiz which we have. And I'm happy to say that one of the questions was from Thyroid Research and Practice. That is the idea. So of the 10 questions that we have now sort of come down to, finally we thought that is the right number. We are requesting one from the TRP, so that increases our publicity and reading. So people are trying to at least access the journal, which should make a tremendous difference. Thank you, Ameya. Then we have Dr. Shanmuga with us. That was a brilliant presentation. And I mean, it has to come from a specialist who is dealing with such cases. And the way you ended up with those case scenarios, I think that added a great value.
Thank you, madam.
And Sujoy, of course, there's nobody like Sujoy as far as moderation is concerned. So thank you, Sujoy, for joining us, for chairing the session today. Minnie is with us. Arun is always there. And thank you, Pramila. I thought Dr. Prasanna had also joined in the beginning for a little while. He told me he was busy, so possibly he logged out later. So we have the support of all the ITS members. Thank you. Thank you very much. And of course, the digital team, we have Ashmita with us. And then from Medisage, we have Priyanka. Thank you, Priyanka, and thank you, Ashmita. For next week, there is a bit of a change. Dr. Brar.
It's in 2 weeks' time, isn't it? 6th July.
Yeah, 6th July.
The chairperson.
Dr. Brar is not joining, and Dr. Jindal will be.
That is the change. That is the change, right?
Yeah.
But I don't see Dr. Brar. Yes. Oh, there he is, of course.
Is
first page.
yeah.
So he will not be moderating the session. We'll have Dr. Sushil Jindal in his place. He has been caught up with some issues. Anyway, so the meeting will go on, and please join us next week. A very, very good night to all of you. Of course, congratulations to the quiz winners. Congratulations. Thank you.
Thank you. Good night.
Good night.
Thank you. Good night. Good night. Good night.
Good night.
Thank you. Good night, everyone.
Good night.
Good night.